We'll go ahead and get started. Good evening, everyone. My name is Dr. Leanne Mancini, one of the physicians of the Family Physicians of St. Joseph. Together with my partners, Dr. Michael Egerbrecht, Dr. Allison Meadows, and Dr. James Gendernalik, we're pleased to welcome you here as we discuss the exciting and innovative topic of direct primary care. Today, we will be hearing from two direct primary care experts in Senator Patrick Kolbeck, as well as Dr. Chad Savage. Senator Kolbeck joins us from Michigan's 7th District and has been an early advocate and supporter of direct primary care. Dr. Chad Savage is an early adopter of the direct primary care model and is the founder of Your Choice Direct Care, one of Michigan's first and most successful direct primary care practices. Our goals today are to educate you on the many benefits and cost-saving capabilities that direct primary care has to offer, as well as to inform you of our own local efforts to provide direct primary care services to Southwest Michigan.
Well, thank you everybody for coming out. You know, it's interesting, we've had a whirlwind day today. This is actually the third presentation we've had about direct primary care today, and I've been blessed to have been with your doctors. I assume most of you are probably part of the practice for the majority of the day. And you have an absolutely beautiful town here. I love the view of the lake and everything. And to think that on a beautiful August day, you guys would come out here when it's that beautiful out there is a testament to these doctors. You wouldn't be here if you didn't like them. It's true. And it's interesting because you'll hear me in the next couple minutes talk a little bit about the system and things that are gone and wrong with it. And my suspicion is that many of you aren't actually fully experiencing that, because I've talked to them and how they've been practicing, and they've accomplished practicing a very high level of care despite the dysfunction of the system. Let me tell you, that is not normal. You have been blessed. But I will give you a quick tour of the way things are for most of the rest of the nation. So I'm a direct primary care doctor. Now you guys heard your doctors are probably going to be, are going to be converting to this soon. And if you were like my patients, your first thought was probably, what? What in the world are they doing? What is this? This is crazy. They've got, what has your practice been here, like 40 years? 40 years. 40 years. And they're going to throw this all away? I mean, they're at the start of their career. What do they commit? Professional suicide here? This is nuts. They must have lost their mind. Well, let me assure you that your question should not be what. It should be why. Why would these doctors, you know them, they're good. Why would they make this decision? It seems very counterintuitive, very against their own self-interest. Well, the answer is, the sad truth is that the insurance-based model of care is extremely broken. In the current system, doctors are massively overworked. Now, a lot of people cynically go, well, doctors are overworked, that's okay, they make a lot of money, that's okay, they shouldn't work really hard. But if you have a burned out doctor who does not seem to care for you, runs in and out of the room, I can assure you, you have an overworked, burned out doctor who's lost the ability to have compassion. And that is huge for being a caregiver, not just a doctor, but a provider of care. We need to care in healthcare. And when they're overworked, it also results in extremely long waits for care. In the United States today, the average wait time to see a primary care doctor is 24 days, more than 3 weeks. And if you're sick and you need to get to see your doctor right now, that is far too long to be waiting. And what that means is that people then are inadvertently diverted to emergency departments, urgent cares, and other places for colds because they can't get in to see their doctor. And sadly, after all that waiting, you're graced with more waiting. The average amount of time that the patient has to dedicate to a single office visit today is 3 hours. Driving in, waiting in the exam room, or in the waiting room. I don't know, it sounds like you guys have not experienced this, but that's the norm. I'm sure you talk to your friends. You'll hear stories of people waiting for an hour, hour and a half in waiting rooms, being forgotten that they're out there. Then they wait in the waiting room. I mean, in the exam room, they're brought back, finally, good, gonna see the doctor. Oh, 20 minutes. Can you hear that? Drunk meeting. Waiting for the doctor to come in. Finally, the doctor comes in, goes out, you're waiting again for checkup, drive home. 3 hours. Well, there's something called opportunity cost. That's the value of your time, and your time is valuable. Time you could be spending at work, or with your family, or whatever it is that you want to do, but it's probably a lot better spent than sitting in our waiting rooms. And I see their new office, by the way. It's going to be beautiful, but I'm sure you'd rather not be just hanging out in their waiting room. And then after all that waiting, you're graced with quick visits, in and out, 8 minutes. Doctor's there, doctor's gone. I waited all that 3 weeks, 3 hours, 8 minutes, waiting all that time for that. And sadly, those doctors are distracted. It's not even a quality 8 minutes. How many people have experienced this? Maybe again, maybe not this group, but this is the standard in medicine today. How are you? Hey, yeah, okay. All right. The doctor's not even looking at you. They're stuck with their computers paying attention to that. They're not bad people, good people, but they have to. That's the way they're paid. That's where they're reimbursed. They have to make that insurance company understand what they're doing. So it's vastly distracted care. They've actually shown in the United States, doctors spend twice as much time documenting your visit than actually meaningfully interacting with you. And sadly, it gets worse than that. There are intentional conflicts of interest injected into the system. The doctors can be paid more to deny you care. And people say that's outlandish, but I'll just give you a quick example. Imagine you were walking along and you step in a hole. You blow your knee out. Oh my gosh, it hurts so bad. You go in to see your doctor. You go, oh gosh, I stepped in a hole, it blew backwards. You think I blew my ACL out. I looked on the internet. It said I needed an MRI to find that out. But your doctor may look at you as moving around. Wow, it does look like you blew your ACL out. Maybe you need an MRI. Wait a second. As the doctor, if I order that MRI, that goes against my high-tech utilization rating. This is a scale that doctors are rated on by their insurance companies. It bases how many MRIs they ordered. Ooh, I've ordered a lot of MRIs this month. If I order another one, I'm going to get paid less. They actually don't look at it as a positive thing if you order the MRI. That's actually considered a negative quality indicator to the insurance companies. You've ordered too many MRIs, doctor. You were a bad doctor. But they were justified. Doesn't matter. The sheer fact that you ordered them, bad doctor, shame on you. Don't order so many MRIs. That is a conflict of interest your doctor should never have with your care. Doctors are historically the advocates of their patients, and that has sadly been leaching away over the last several decades. Now, I have never seen a graph that more succinctly describes what's happening in the United States than this one. So let me describe it here quickly for you. This brown line that you see here on the bottom, that's the number of doctors in that 4-decade period of time between 1907 and 2010. And as you see, it's relatively stable. There's a slight increase in doctor supply during that period of time. But the yellow, see going up here, is the number of administrators within the healthcare system. And as you can tell, there has been a veritable explosion of administrative burden, i.e. bureaucracy, injected into the system. And the black line, that's per capita spending, how much each of us spend on healthcare. You and I spend every year on medical care. And as you can see, it's much more closely trending with the explosion of the bureaucratic administrative burden in the medical system than it is with the supply of doctors. So it's a false argument that we are the drivers of these increasing costs. In fact, the problem is so bad that in 2010, according to the Department of Labor and Statistics, there were 4.5 million Americans whose job title was healthcare administrator, and they were administering approximately 700,000 to 800,000 actively practicing doctors. And what this feels like, unfortunately, is the 800-pound gorilla of the third-party payer system. Doctors, third-party payer system is insurance companies and the government that accompanies that doctor into every exam room, every day, with every patient. And they tell them how many people they need to see, what questions they can ask, and even dictate the treatment plans. Kind of sounds like practicing medicine without a license to me. Now, I wouldn't bring up a problem unless I thought there was a solution, and part of that solution is something called direct primary care. So what is direct primary care? Direct primary care is a membership model of medical care. Low cost, monthly membership, where the doctor works directly for the patient. Because of this, there are no billing hassles. Has anybody ever had a bad bill? Goes wrong? Anybody ever tried to deal with that and figure it out? Talk about a nightmare. There are also no conflicts of interest. So that doctor is your doctor. So they've got your back. It's a rat price. It's budgetable. It's predictable. It's affordable. So you don't get these gotcha bills that people are getting all the time. You go to the ER, you come out of the ER, you don't even know what it's going to cost. A couple days later or weeks later, you get a bill. Oh my gosh, what? You think you're done. Nope. 2 days later, another bill comes in. Oh my, another one. And then another one and another one. You get a series of bills. That's the norm in medical care. You're writing blank checks all the time. You have no idea. You will know with this practice what you will spend way before you ever spend it. So you'll be able to determine whether it's actually worth the value or not. I think it very much is, and I hope to describe that for you shortly. These practices, by design, have limited patient bases. In the United States today, it's very common for doctors to have 2,500, 3,000, or even 4,000 or more patients. I myself had 3,500 patients when I was an insurance-based doctor, and I will tell you, as hard as I tried, you cannot give great care when you have that many patients, and it is a historic anomaly. Prior to 1980, the average doctor had 1,000 patients. So what we're doing in direct primary care is not the anomaly. The current system is the anomaly, and there are, by intent, numerous barricades to your care when you have that many patients per doctor, where you can't have easy accessibility. But because it has more limited patients, you're able to go back to that historic norms. And I see some people with gray hair here. You may remember when you saw your doctor, you called them up and you could get in to see them. This is a hard thing nowadays. Well, we go back to that because we go back to historic norms of doctors to patients. And now you can get same day or next day availability. And not only do you get that incredible availability, but you have time with your doctor. Direct primary care doctors schedule in 30-minute and 1-hour increments. So if we ask you, anything else going on? We actually mean it. When I was an insurance-based doctor, I'd ask that question a lot. But on the inside, I'd go, oh, please don't say anything. Please don't. I've got to run. I'm like 20 minutes over, and I got tons of patients to see. In our model, we honestly sit down, relax, talk to you, and we find out if you got anything more, and we really honestly want to know. And it's beautiful because we get to develop that doctor-patient relationship that is so therapeutic. It also is patient-centered. People who are in healthcare policy have heard the term patient-centered medical home. It's a new catchword in the medical community, and it's a new way of reimbursing your doctor. But the unfortunate truth is once you look beyond the title, the patient-centeredness ends there. It is all payment-centered medical home. Everything is about, if you do this, we'll give you an extra 1%. If you do another thing, we get another 0.5% uplift here. And that's what they call them uplift. They say pay you more if you do what we say. That's what they really should be saying. But so what does that look like? So what does a membership model of medical care look like? So it includes all of your office visits. If you come in for your wellness visit, that's included. We don't charge anything for that. You get sick, come in the next week, we don't charge any more. It's all wrapped into that low-cost, budgetable membership model. It's about the price of a gym membership. And now, why is this important? Studies have clearly shown that if you increase the amount of cost to see your doctor, you see your doctor less, or you see them less promptly. And this has been shown that though you decrease the cost of primary care doctors because you're utilizing them less, you double that savings in new costs of hospitalizations. Why? Because people are waiting to go to see their doctor. They're delaying accessing care. So they're coming in sicker when they see the doctor, more advanced their illness, to the point we may not be able to treat them now. We have to put them in the hospital. That is a huge financial toll, but much more importantly, that is a catastrophic human toll. These are people who are ill. These are people who could die because they delayed care. In this model, that motive is gone. Your doctor is restored to the screener of disease that we were trained to be. So you come in, you don't have a disincentive to use your doctor. You need to see your doctor, come in and use us. We don't, well, not me, use them. You get the point. I'm on the, and if you want to drive the west side of this, or east side of the state, that's great. But it also includes all of the in-office diagnostics. EKG, spirometries, pulse oximeters, strep tests, urinalyses, all the testing. So if you say you got to get a urine dip, well, we don't worry about billing it, coding it, tracking it down, sweating it, just do it. Just get it done. They cost about 10 cents to do. EKG, will normally bill $50. No, just do it, just get it done. So you don't have to worry about getting nickeled and dimed every aspect of it. It includes all of the in-office procedures, cryotherapy, joint injections, ear lavages, all the things you would classically do in a primary care office are included within that membership. And this is what I think is really innovative. It's something that I call virtual home visits, because I think it encapsulates what we do. It's also known as telemedicine. It's using technology to give you the ability to access your doctor remotely, from home, from work, on vacation, wherever you may be. You now have the ability to, through technology, interact with your doctor. Text message, Skype, telephone, all these things that are hard to use in the current system. And this is revolutionary. And I'll give you an example. So imagine it's a Saturday morning, and you were out in the garden, and you got an itchy rash, and you think, oh gosh, it's Saturday morning, I saw that poison ivy, but oh man, I thought I stayed away from it. Oh, this itch is something fierce. I'll wait until Monday and I'll see my insurance company doctor, but wait a second, it takes takes like 3 weeks to get in. I'll be lucky if I get in this week. Oh, this is terrible. I can't stand it anymore. I'm just going to the ER. Well, forget all that. Under our model, you pull out your cell phone. Take a picture of it. Text it to your doctor. Hey doc, I was in the garden yesterday, got this terribly itchy rash. Think it could be poison ivy? Your doctor texts back. Why, that does look like poison ivy. Try some triamcinolone ointment. Let me know if you don't get better. That's good, efficient, cost-effective. You got nice access to your doctor. Quick, Saturday morning, when you otherwise would have had to go to an urgent care, an emergency department, spend a lot of money. It's good care. It's good for your doctor too. You got a history in the garden, got itchy rash, you got a physical, got a high definition image, you got a treatment plan, try some triamcinolone ointment, which is called in for you, and you got a follow-up plan. Let me know if you're not better. Wonderful. Great for the patient, great for the doctor, great for a third person who I didn't mention. And that's the really sick person who had just got discharged from the hospital, congestive heart failure, and needs more time with that doctor. That doctor, now given the freedom to allocate their limited time resource more appropriately, can take care of that person who could easily be handled through technology on a Saturday morning in minutes through a text message, and can dedicate more time to the person who truly needed their care on that Monday and is not rushing out of the room of that patient who needed them to get the poison ivy treatment. So to make things more affordable, direct primary care docs combine what we're doing with massively discounted imaging, with massively discounted labs, and medications. So let me give you some examples. So anybody know what a CBC is? I know it's embarrassing talking in the crowd. CBC is great, so we use them all the time. It's white cells, which are immune cells. It can indicate infection, indicate certain types of cancers like leukemias. It has hemoglobin and hematocrit, which tells us anemia. You've got platelets, which are clotting cells. You can get cell size, which can suggest things like iron deficiency or B12 deficiency. It bills for about $85. They can do them for $2. And they don't got some guy with crazy hair in the back room tilting beakers doing this. They're using the exact same labs that the hospitals use, but this is what the hospitals pay. What they're doing is they're acting as a financial pass-through. They're doing something called client services billing. They're allowing you to get the prices on these things you could never get on your own. By getting the same prices the hospitals get, but not giving you 2,000 or 3,000%, and I kid you not, 2,000 or 3,000% upcharge that you get on these services, and just giving it to you directly. CBC is real common, $50 to $80, very common charge for those, $2. But as you guys all know, we don't just order CBC. Why? We like ordering CBCs and CNPs and lipid panels and TSHs. You can add that up, and that could be hundreds of dollars through the insurance model, but it's about maybe 20 or 30 when you do it directly. And if you have a high deductible plan, you are paying that difference if you don't get it through a direct approach. Now, it's also legal in the state of Michigan for doctors to dispense to their patients if they have a license to do so, which we all have obtained in the direct primary care movement. And we have in-office pharmacies where we can dispense medications directly to our patients. And let me just give you some examples here. So first of all, Z-Pak. Everybody knows that antibiotic pack, $1.47, right? It's like $35 even with the best cash pay prices. I love this one, Zestrol. This is a blood pressure medication. Treats high blood pressure, treats congestive heart failure, helps diabetics with kidney disease. Great drug. Hypertension, one of the leading causes of preventable death in the United States. You can treat an entire month of it with a quality drug for 24 cents. You can treat one of the leading causes of death for an entire month for less than the cost of a gumball. We have people who don't get medical care because they can't afford this stuff. What we do is we go to the distributors at CVS, Rite Aid, and all these other places do, and we do the same thing we did at the labs. We just don't upcharge them. We dispense them at our cost to the patient. This is what they actually cost before you got a 2,000 to 3,000% upcharge. But also they've made negotiations with regional imaging centers to get you good prices. Now Beth, right? Beth, we were just talking before we came in here. We went to lunch, had salmon. It was great, in case you're wondering. Okay, you were wondering that, right? We were talking, and she was saying that, what was your son? So her son just had an MRI of his knee. He blew out his ACL. It was probably an apt story, right? He did some meniscus, okay, cartilage in the knee. She got an MRI. The bill rate was $5,000. But that's okay, guys. She had insurance. She had an 80-20 plan. She only paid 20% of $5,000. Well, what's that? it's $1,000. So well, look at this. You can get an MRI. This is of the lower spine, but this is analogous for $376 with no insurance, with nothing. It was a totally false charge that was rampant in the medical system. The prices are totally factitious. So she would have been almost help me quick, $624 better off, and she ignored her insurance altogether. So how much is this got to cost, right? Unlimited primary care, all your primary care office visits, discounted meds, discounted labs, discounted imaging, no conflicts of interest, all the in-office testing, all the in-office diagnostics, telemedicine. How much is that got to cost? Well, it's probably a lot better than you think. Prices start as low as $15 a month for kids, and you can cover your entire family for $150 a month. So what do you get for that, right? I mean, I just was talking about it a little bit. Well, these are just an example, and you guys, you don't believe me, go on their website and confirm all of this. So under that membership, you can get same day or next day acute visits. You can get annual physicals, wellness visits, school and sports physicals. You can get all your chronic care management visits, newborn pediatric care. You can get DOT physicals if you drive a truck. You can get unrestricted access to your doctor, group and individual counseling. You can potentially get home visits. You can get spinal manipulation in case you see a chiropractor. You can get reduced prices on diagnostics, low-cost medications, DME, splints, braces, EKGs, low-cost labs. You can get spirometries. You can get skin biopsies. You can get cryotherapy, which is freezing wards. You can get joint injections. You can get colposcopies, which are gynecological procedures. You can get tetanus shots. You can get flu shots. You can get point-of-care labs like INRs, PTs, urine pregnancies, hemoglobin A1C, urinalysis, lead testing, hemoglobin A1C, I think I spit on the microphone. You get a lot of stuff for that. So that is not just, a doctor's visit. No, it's a lot more. So it was an interesting thought process when I was looking at this, and I was looking at it, I thought, well, okay, that's $150 a month. They give discounts too. By the way, if you sign up for a year, you get a month free. You get snowbird discount, you get other discounts. I don't remember them all. But so they have other ways of making it even cheaper. So I said, well, if you did an annual membership where they drop a month for you guys, and you were to figure out the daily costs of one of these memberships, you can get, first of all, if you're over 99, congratulations, it will take care of you for free. How long, I don't know, but with their care, probably a long time. But you can get unlimited primary care for your entire family for $4.25 a day, which makes me ask, how much do you spend on your coffee this morning? So, I'd like to just take a minute and explain insurance coverage to people, because there's a lot of misunderstandings about insurance company coverage. Many of us, unfortunately, have been raised never having access to care other than through an insurance company. So I would argue that a lot of us have been brainwashed to think that this is the only way you can access medical care. Quick disclaimer, I am not a financial advisor, so verify everything yourself. So this is general ideas and recommendations. So direct primary care works really, really well with high deductible insurance plans, specifically PPOs. HMOs can give us a hard time. They work extremely well with the non-traditional Christian health sharing. 4 of them, MediShare, Liberty, Christian Healthcare Ministries, and Samaritan. 3 of those you have to be a Christian for, 1 of them you don't. They are fantastic. I'll explain them in a second. And if you're a business owner, there's something called ERISA, which means you can do ERISA-based plans. You can create self-insurance. Works really good because we try to decrease your costs. So let me introduce you to the Johnson family. This is my hypothetical family, but these are actual insurance quotes. So I went out and I went on ehealthinsurance.com, which is one of the easily accessible exchanges, and I got quotes for this family of 5. 2 parents in their 50s, early 50s, and then 3 kids mostly in their teens. And I wanted to say, if they were to buy insurance on their own and they're not bearing it in an employment contract, if they're not getting a lot of subsidies, let's say they're a real estate agent and they're actually buying it on their own, how much would it cost for them? And so I used this zip code. So this is your local for you. And the red, so let me explain this. The red here, that's your premium. That's what you're giving the insurance company every month. Over the course of the year, these are annual numbers. No matter whether you saw a doctor or not, this is how much you pay your insurance company over the course of the year. The gray, this is your deductible. Deductibles are what you have to pay in medical costs before the red, the insurance company, does anything. And then the brown, which is on the top, is what's called out-of-pocket maximum. That means a lot of people go, I'm done with my deductible. Great, everything's free from here on out. No, not so fast. Most insurance companies charge you co-insurance, co-payments beyond that point. Most of them are 80-20, meaning you, just like Beth, you pay 20% of a false price, which means you're probably getting ripped off even then. But you can pay up to an additional $10,000 in out-of-pocket costs when you get the gold plan. So look at this gold plan here. So this is, before they've ever seen a doctor, this family is spending $32,000 in medical costs, and they have not yet even seen a doctor. Once they start seeing doctors, you start eating into this top part here. And it is possible in a bad year. So I designed this to reflect what would happen if you maxed everything out. The worst year, you got surgeries, you're in the ICU. In the worst year of your life, that family's paying an additional 10 grand on top of that. They're paying almost $45,000 in medical costs that year. Now, if they're smart, they're going to look over here and they're going to see this bronze plan. And the red goes down, the premium goes down about $14,000 just by picking up a deductible. Ooh, that's a high deductible. Remember, that's what you got to pay before your insurance covers anything. It's $14,000. But wait, I said $14,000 twice. The premium went down 14, and they added a $14,000 deductible, which means in the worst year of your life, even if you use the entire $14,000 deductible, it is no worse than the gold plan every single year. So if you have the only thing you've done by getting the gold plan is insure yourself financially the medical worst year of your life every single year. And you have potential paying more than that. So there's a great misperception that if I get this really expensive insurance, I'm going to minimize my financial risk later. That's actually not true. Look at these graphs. These are real quotes. Now people look at that gray and they say, ooh, I'm at risk for $14,000, right? I may have to pay $14,000. I don't look at that as risk. I look at that as opportunity. You were going to spend that if you got the gold plan. You may not spend that if you get the bronze plan and you're a rational consumer of healthcare and you're getting good prices and you're getting good medical care. Maybe you only spent $2,000. Well, now you just saved $12,000 over getting the gold plan. And here's the other thing, the best kept secret in medical finance. Christian healthcare. So that entire family, this is not an insurance plan. These are not for everyone. But they do function very analogous to insurance. They are ACA compliant, meaning if you have them, you do not get an Obamacare penalty. They consider this adequate insurance coverage. Adequate coverage, not insurance. But they function, they cover hospitalization, they cover surgeries, they cover things like that, as long as it's not pre-existing. So there are some stipulations, make sure you know what you're getting into. But if you're relatively healthy, these are really interesting option for a lot of people. So that means if you even compare it to the bronze plan, you're decreasing the premium by almost a third. So now you're going from $18,000 to about $6,000. And you're taking that deductible, they don't call it a deductible, they call it an unshared amount, but it's analogous, from $14,000 down to $1,500. So you're decreasing the premium by a third and you're decreasing the deductible by 90%. So let's take a look at that, how that works. So that's just insurance coverage options by itself. How does that work with direct primary care? So if you're to say, well, okay, great. Now I'm going to try to avoid that really expensive product. And then I'm going to try to get a service that makes it so I spend less on medical care when I actually access it. So the green line you see here, that's these guys. That's St. Joe's family practice. That's their family rate for an entire year because they drop a month off, right? So that's that little green bar here at the top. And if you get that, you may use a lot less of this gray bar here. And I was looking at this, and it's kind of interesting because this little green line, again, is unlimited primary care for 80% of your care. 80% of medical care can be provided out of primary care offices. So I thought, how many years could you see these guys, if you're a family of 5, if you change your coverage product for 1 year only? And you could see them with unlimited primary care by almost 4 decades by changing how you pay for your coverage for 1 year only. And it's not as though you're foregoing care that year. I would argue you're getting better care for all the reasons I spelled out earlier about what direct primary care is. So this is looking and being wise about your coverage selections. Now I also thought about this, I thought, man, it's a lot of money. How much does that break down to a daily basis? How much, when you're spending that much money on an insurance product, what is that? So take that $32,000, You divide it by 365, and these are the numbers you get. So that person who is buying that gold plan insurance is spending essentially $90 a day, every single day, whether they see a doctor or not, 365, weekends and holidays, every day for their insurance coverage alone. And if they get sick, they add on the gray and they add on the brown, which means their total daily cost, averaged out over the entirety of a year, is essentially $118 every single day. You could, on a cash market, you could essentially see a doctor for that every day for the entire year, weekends and holidays, 365 doctor's visits. That's nuts. Now, if you just change it and you go down to Liberty Health Share and you tack on, and you assume you use their deductible, and you tack on the St. Joe group, you're dropping down to right around $20 a day from $118. You're saving $100 every single day. So that little green line, you see it there? See that? See it? Let me see. I'll point it out to you in case everybody misses it. See it? Right there. This one, right? See it? Okay, good. This, just make sure, right there. That little green line, that's 80% of your medical care. So I've talked a lot about dollars and cents here, right? But we haven't actually talked about worth. Worth can be more than that. So what is it worth to you to know your doctor has your back, is working for you, is your advocate? And I'd argue it's priceless. So, to summarize, direct primary care. Low cost, monthly memberships. Includes all office visits, all in-office diagnostics, all in-office procedures, telemedicine, discounted labs, discounted imaging, discounted medications, no billing hassles. But best of all, no conflicts of interest. You know if your doctor says something, they're doing it for you. So direct primary care, future direct primary care doctors being doctors. So I'd like to thank you all for your attention.
We're going to go ahead and take some questions now, but before we do, I do want to introduce one other member of our panel, Dr. Ken Fisher, retired nephrologist, author, advocate for direct primary care as well, to help us answer some questions as well. In order to do this, if anyone has any questions, we ask that you just step forward to one of the microphones. Come on down. Not scary.
How does this interface with Medicare, things like Blue Cross, if we've got it now, what do we do?
Okay, well, so it's interesting. So I spelled out a scenario. I know, you know what, I'll give it to them.
I can kick it off, and then you can talk about it in practice. I'll talk about it. He's awesome. Yeah, I know. Because I'm the one that gets to break the bad news first, and he'll talk about how we can go off and deal with it in practice. So right now, Center for Medicaid and Medicare Services will not reimburse directly for direct primary care services.
That's okay. I just want to make sure that we're not overlapping.
Yeah, no, we've got to break it into, like I was starting off, there's a primary care and catastrophic care. You can still go off and be on Medicaid and get your catastrophic care covered by Medicaid. And then a lot of people, a lot of enrollees across the state will actually, even though they're on Medicaid, will pay the extra $50 a month or whatever to go get guaranteed access to a primary care physician. Because the truth of the matter is, right now a doctor gets 17 cents on the dollar when somebody visits them from Medicaid. And so that leads to doctor practices closing their doors to new enrollees around Medicaid. And because they can't afford to have a whole practice where they're only getting 17% of their costs paid for. And so it's a big deal. Direct primary care blows that out of the water because now you get rid of the Scarlet M form. Actually, I was successful at getting a direct primary care Medicaid pilot kicked off in this last budget cycle in the state of Michigan. So this pilot's going to last 3 years. It has 2,400 enrollees associated with it that are eligible. And we're going to prove out, unlike what they've done with other healthcare reforms. I'm an engineer, that's my background. I want to prove it, validate the assumptions that we're going to save people money by getting them better care. Once we prove it out, we'll roll it out to the rest of the 2.4 million people in the state of Michigan. So that is a pilot that we're getting a special exemption for right now. In Medicare, there's a federal initiative where they're doing something that's kind of a hybrid of direct primary care and traditional fee-for-service. They'll pay a doctor $20 per month for this as part of this. So directionally, everything's headed in this direction. Practically, it's not something that you can be directly reimbursed for in regards to Medicaid or Medicare.
That's fine, just you're over there, you're over there. You're a cash insurance.
Yeah, so it's an interesting question. It's a good one, actually, because we get a lot. Yeah, the examples I used, right, we're in an idealized situation where you can control your costs and you therefore have the ability to decrease them. If you have Medicare, you're a little stuck, right, because you don't have the ability to change that easily. One of the key recommendations is try to avoid Medicare Advantage, and Medicare Advantage is a Medicare HMO. HMO, for people to understand, they really need to control your doctor. They really tell your doctor what they can and can't do. That is actually the epitome of conflict of interest. Well, so it's an interesting thing. So we can still use, I have a ton of Medicare patients. And what we do is we can still order things under Medicare. The only person who can't take a Medicare payment in this model is these guys. Well, actually, they are going to take Medicare payments for at least another year at least. So you get to try, you get to kick the tires. How awesome is that? You can find out if this is worth it to you or not. But once you get there, my patients, I'm departicipated. I don't take Medicare anymore. So I don't take a Medicare payment personally. But that doesn't mean I can't order an MRI, and if Medicare is going to cover it, they don't have to use cash pay routes. It's an option for them. If it's cheaper like it was for Beth, they can do it. And if it's not, they can use Medicare. It'd still honor my orders. But it's interesting because depending on your insurance options, whether it's Medicare or some other insurance, your amount of savings may vary. In fact, there are situations where if you can't change your insurance coverage at all, it may not always be cheaper. We do the things like including all the testing, and you got no co-payments, we get you discounted meds. So we minimally cut into that cost. So it's never what the annual rate is because you have to subtract out what you would have been spending on meds, labs, and other things. So it's minus all that. So frequently we can get people, even on Medicare, essentially back to zero, which means they threw us in for free. Well, that's pretty sweet, you got your doctor for free. But even if you don't, it ends up being like $50 more, $70 more over the course of a year, you're getting much better care. So is that worth it? It's everybody has to decide for themselves. But I'll tell you, it's not always, in every possible scenario, cheaper. It is always, in every possibility, better. It is better care. Unconflicted, better access, duration of visits, accessibility, et cetera, better care. And then, did I answer your question?
Yeah.
Right.
You kind of go over.
I think this is a good time to talk about the frog in the water. I mean, how many times have you heard that you put a frog in the water, you light the stove, the fire under the pot, and slowly the water gets hotter and hotter, and eventually the frog is cooked? Well, that's us. We, for the last 50 plus years, have seen an encroaching third-party dominance in healthcare. And it's been slow, and we have been cooked in the process. A guy by the name of David Goldhill, who was a business executive before he started writing about healthcare, calculated what his secretary is going to pay in the American third-party healthcare process. Take a guess. That would include the premiums that he's paying so that she doesn't get that salary. That includes the tax money she's paying to cover Medicare and Medicaid. That includes the tax for state and tax for local for their health care. Take a guess what a secretary over a lifetime pays in this third-party model. Just name a number. $1 million. Do I have 2 million?
Yes.
Yes. What about 3 million? Yes, it's $3 million. A secretary is in essence worked her entire life to support this third-party system. So what is happening? Finally, people are saying, I'm not going to be a frog in the water anymore. This is ridiculous. I am going to do things that Dr. Savage has suggested. This is insanity, folks. This is total insanity. And we are stuck in this thing. And it started with Medicaid, Medicaid and Medicare being passed in 1965, and then also with health insurance morphing into prepaid health care. It's not insurance. When you have insurance on your car, if you get new tires, you get gasoline, you get oil, you don't ask the insurance company to pay for it, right? Insurance for a car is you demolish your car and hopefully you'll get something for what it's worth. We just had an example where our daughter has to buy a new car. She's getting pennies on the dollar for what a car was worth to her. Okay, so it has morphed into prepaid. It's not insurance. This is another part of the frog in the water. You see what I mean? It's not insurance, it's prepaid health care. Listen to this. Your employer is paying for your insurance approximately $500 for you to then get $50 back to see the doctor. With all that, remember the yellow? That's what's going on. So we are sacrificing the future of our children and our grandchildren in our retirement so that yellow can keep on going up. 4.5 million people who have nothing to do with healthcare counting money, and that's where it's going.
I can't help but answer the Medicare question because I get it a lot. Can you guys hear me? I think you can. So one thing that's very difficult is to help a Medicare patient who comes in with a problem list, and by problem list I mean congestive heart failure, chronic kidney disease, history of pneumonia, I could go on, and high blood pressure, and then they come in with a list of 10 different medications. In a typical 15-minute office visit, I'm going to tell you it is very hard to squeeze everything in that you need to get in. So for me to review the medications, make sure there's no drug interaction, see what specialists have given you, review tests that you've had done since your last visit. It's virtually impossible, and I would challenge any of my friends to say they can do that in 15 minutes. I know I've been practicing longer, but I just can't do that in 15 minutes. I need a half an hour with my Medicare patients. I can't stay in business by seeing you for 30 minutes and billing Medicare. They don't pay us enough to pay all of our bills and take care of Medicare patients. I'm sorry, that's just the reality of where we are in our healthcare system. So to be able to spend 30 or 60 minutes with somebody, what's the price on that? I think one of Dr. Savage's last slides said priceless. I don't know about you, but if I have time to spend to work through your medications, review what your cardiologist has said, and give you like a synopsis of what really is going on with your health, I don't know what's that worth to you, to anybody really, because the state of healthcare in this country right now is you're going to get 10 or 15 minutes with your doctor, and like Dr. Savage said, you're going to walk out and say, what just happened? Does he really know what my cardiologist read on the echocardiogram last month? Probably didn't even look at it, didn't have time. So it's time. Time with your doctor is just very hard to realize how important it is. So that's my big message on Medicare.
Do we have other questions?
We have a fixed income. I have Medicare and supplemental. So does that mean I would pay my $75 a month plus my supplemental, or can I lower the supplemental a little bit?
So once you have chosen a supplemental, it is challenging to change it, but it is possible. So that would be if you have an insurance agent who you are comfortable with, then I would discuss that with them about what options for supplementals would work best with the DPC program. But yes, that is a possibility. So you can lower that price or that cost that you're paying for the supplemental insurance. Yeah.
Thank you.
Tony, do you want to comment on that, or do you feel like? Okay, thanks.
How do you determine eligibility for a program? I mean,
If-
some of us are older than others, and we've already got a few things we're dragging behind us.
You know, somebody kind of asked a question similar to that earlier, if we, kind of cherry pick our patients, or if we have a certain demographic in mind who we want to see. And no, we don't, because really, if you think about it, anyone could have any medical condition at any point in their life, and we don't know who's going to have what. And so we really want to offer our services to anyone who wants to be seen. So anybody is welcome to see us, and we welcome you all.
Oh, sure.
Oh,
Yes, you wanna-
the question was, how do you choose who you see?
I gathered that from Robin.
Sorry, I'll repeat, I will, sorry.
Very good.
I'm new to Medicare. I will be eligible in April. Do I have to go on Medicare?
I believe so.
I have no choice.
If you don't go on Medicare, they'll take your Social Security payment away. I mean, this is government overbearing fraud. You have paid into this all your life, and if you don't do what they want you to do, they'll take it away from you.
I like the sound of the plan, and I don't know what's going to happen in April with my doctor if you're no longer going to take Medicare patients. Is that true?
So we're still going to be seeing Medicare and billing Medicare until October 1st of 2018. So if you do not go on Medicare until April, then you would need to pay the monthly membership fee between October and April to continue to be seen. But then after
Yeah, I
April, we'll
understand
pay
that
for
part of it.
Medicare.
But then in 2018, you're going to discontinue Medicare patients.
No,
We are not going to bill Medicare anymore.
Right.
So if you are still a patient and you want to pay your monthly membership fee,
Yeah.
then we will continue to see you. But we will just not be billing Medicare for your services. So,
Okay, so I still have supplemental Medicare
yes,
and my monthly membership.
correct. And if you have not already
Now, the
signed up.
supplemental can be managed way down.
Correct. Yep, so I was just going to say, if you have not already signed up for Medicare, you're in a great position, because this is the time where you could discuss with an insurance agent what the best supplemental would be for you and get a
You
good,
know, my agent
good plan.
doesn't know what direct primary care is.
well, Tony right here does.
Hello, I'm right here. I'm a new agent. There you go. I like this. You do your best business on Main Street.
I'm glad we could serve you.
I got a new agent. All right, that answers it.
Thank you.
Yes, I've got a plan.
Okay.
Before I was, wondering, right now I'm going to call my agent that I've got and lower my Blue Cross Blue Shield to the absolute cheapest, sign up for the 75, because I know when I go on Medicare, they take it out of your Social Security, and the numbers, it's pretty close to what I'm paying right now, as far as, my monthly health insurance and Blue Cross Blue Shield. Medicare is going to be just a little bit cheaper, but they take it out of your Social Security, so you're still paying for it.
We're a fraud in one.
So I don't know, how this is all going to play out, but I like the idea of prescriptions and then different tests and diagnostic things. Like if I was, came in with a kidney that was acting up, and the doctor said, let's do some tests, okay? And could you do tests that would save, if I had to go to a urologist, could you do some tests so he doesn't say, oh, we have to do these tests? Well, you could have had them done, say, with your plan. Is that possible? Is that working the system?
So I would say this, that one thing I'd like to make clear is that we're offering
access to cash-based lab pricing, cash-based medication, cash-based diagnostics.
Blood tests for kidney
If you
failure.
want to do that. There are patients who might have Medicare in their supplement and they'll say, I'll pay $5 if Medicare and my supplement are billed for that CT scan. Just send me to the hospital and do it. But what we're saying is there's an option here if you want it. We're not making anything like that mandatory. It's optional. So some patients might really like it.
So when something happens, there's some decisions that have to take place as far as, you know, where do I go first?
Yeah, and if you go to see your specialist and your specialist orders labs, you know, you have to get routine labs that the specialist is wanting you to have done, you could certainly come and get the cash-based pricing through us so that you aren't having to go and submit that
I
order.
could go backward. I could backward.
Sure, exactly. You could bring it back and we will honor
So I
that order.
could tell Dr. Terhune that, you know, Dr. Egerbrecht has a better deal going. No problem.
Right. You know what? Just text me. And
All right.
I'll tell you to come in.
We'll
take
get on
care.
Skype.
Yeah.
We'll go Facebook.
This is, if I could, thank you. Appreciate your question. I think, did you have more to add?
No, I'm done. Thank you very much. Thank you for hosting this.
In talking to Dr. Savage today, by the way, I really appreciate you coming again because he's been very helpful. But one thing I'd like to say is we do have patients who will say to us, well, I only see you once a year, why would I do something like this? And one thing I've learned from Dr. Savage today is that he sees patients who will contact him at least 4 times as much. I think that was kind of your...
Yeah, they've actually found because
multiplier.
there's no copay that we actually get sicker people. I'm sorry, we actually get sicker people. I mean, who does that low-cost monthly membership sound good to? The person who says, well, I haven't seen a doctor in 4 years, I'm going to pay you monthly? Or the person who goes, awesome, I'm there every other week. You know, we get what's called adverse risk selection. We actually get the sickest of the sick. And that's cool. We take care of sick people. That's what we train to do.
But we're available to well people too,
Yeah,
because
we're gonna choose them all.
I talked to somebody just a little while ago this evening, and you know, kind of the typical question of I only come once a year, why would I do this? Well, can anybody predict when they're going to have a kidney stone? Can anybody predict when they're going to have a slip and fall? I saw a lady in my office yesterday, generally healthy, patient of my partner, fell and had a fairly significant injury, had to get her right in, had to get some diagnostic testing done. I'm thankful that she didn't have to wait till Monday to see us. And we got her right in, and that's one thing that we're really committed to is access. And it's one of our vision elements is access.
And actually, this is kind of one of the most fundamental aspects of what we're talking about with direct primary care. This is a service now. This is something where you go off, just like for an oil change for your car, or go fill up your gas tank with gas. You're actually getting a service now. This is different from what has developed into the insurance model. That's about risk management. When we ask questions about adverse risk selection, we start talking about, hey, are you going to go off and try to, you know, only pick the healthy people and stuff? No, this is actually getting the mode where you're going to a place that you know you're going to get access to that service. You're not sitting there waiting for some third party to go off and tell you whether or not you can get access to that service. It's a drastically different way of looking at healthcare, and frankly, it's going back to the way healthcare used to be.
I want to thank you for the presentation this evening. I've really learned a lot about the plan, and I find it much more attractive than I thought I would. Everyone's case as far as coverage is different. I'm sure you could probably hear 200 descriptions. The one question that seemed to surface that I would like to voice is there a maximum client base under this plan for your practice?
Well, Dr. Savage had a slide that said under 1,000 is the typical patient panel, and I can't say that each one of us has sat down and said, well, I have room for 750, I have room for 825. I mean, we're going to do our best job to take care of patients as well as we can up to that mark. Will we each be at 1,000? I kind of doubt it, because our goal is to have access, be available, spend time, and take time beyond seeing patients to maybe look something up for you. So long answer, less than 1,000. So probably
Per physician,
yeah.
not per practice.
Per physician, yeah.
I'd like to just comment on the previous question. What if I only see a doctor once a year? Why would I do this? Right? That was the question. But think about this for a second. You're willing to spend $1,000 to $2,000 a month for health insurance, right? On the other hand, this practice is saying, why don't you spend $50 a month with us and forego that $1,000 a month for real care? So you see how we've been trained? You see the last 50 years has done to us? It's better to spend $1,000 and get lousy care than it is to spend $50, $75 to get wonderful care.
And this is actually an example that I pulled from my own family when we looked at a gold versus a bronze plan. And you can see with the gold plan, the premium was over $10,000. By adding direct primary care plus a higher deductible plan, which was much cheaper, the premium went down to $3,500. You can see that even though you add that, the deductible went up, by the time, and you add that direct primary care membership, the annual savings was over $5,000. So even though we went up to that higher deductible, and we didn't see that, you know, we came in for our wellness, so we only came once a year, we still saved money. You know, that was just the math for our family.
Oh, no, I think all he said was that there are 4 health sharing ministries out there, and so he was just saying that you have to be a Christian, a self-identified Christian, in order to participate with 3 of them, but the 4th one, you do not have to self-identify with that religion to be part of it.
But you are affiliated with those 4?
No, we are not.
We're not affiliated. We
I
can.
thought we came through their...
No, they are just options. He's just mentioning those as options out there.
Because remember, we want you to have ideal is to have some sort of catastrophic insurance, and then if you couple that with direct primary care, that's an ideal combination.
Well, MediShare is the only one with a senior supplemental. Oh, yeah, MediShare, yeah, that's a good way of thinking it.
Yeah, and just for everybody else's benefit, remember when I was talking, we had primary care and catastrophic care. Medicare, you can treat and look at as the catastrophic care element that you can combine with an out-of-pocket payment for the direct primary care. So, and you can substitute Medicare with high deductible health plan, with a healthcare ministry, with a self-funded or ERISA-based plan if you're an employer. Those are all substitutes on the catastrophic side.
Right over here.
What if we get sick when we travel?
I'm not going to pass the microphone. I'll just keep Sorry. I'll save you a few words. So the question is, what if you get sick when you travel? So if you're in Florida, like at Disney World or something like that, so you can call us or text us, or we can make arrangements to work with your mom or whoever and figure out what the best option is for you. Sometimes we'll send you to the emergency room if you're real sick, and sometimes we'll give you advice on what to do. So, so you can call or text. We might even be on the computer looking at you, talking to you.
Very good question.
Thank you.
You're welcome.
So that's actually an interesting question. He just added, is there a network of cooperative doctors? And actually there kind of is. There is a very rapidly growing movement towards direct primary care, and there's a lot of discussion amongst the DPC doctors about being able to kind of share if you have patients who are on vacation and you know that they're in that location, would we be willing to exchange services? So, you know, I think we all share the same goal of providing good care to people and being there for people, and so we all have that kind of mentality. So that's certainly maybe an option.
Hi. I just want to say a few things. It's more of a statement than anything. So I'm in healthcare, and when I heard about this, I was so excited for this practice because it's very innovative. It's very state-of-the-art and outside-of-the-box thinking, I feel, as a participant of healthcare and a professional nurse. So I just want to say thank you for doing this, and I think that there's probably some other precipitating factors that led you to this route. Can you address those, or is this... Okay, so I'm just going to say, I mean, is this to avoid becoming a Lakeland affiliate or part of Lakeland, and you're being brave to do this on your own, or do you want it passed?
I would not say that that was our driving force, not at all. We didn't have a discussion about that.
No, but we do want to stay independent, I think, and own our own business and our practice. I think that was a very important piece to all of us, because we get to maintain control. So it's not we want to stay, independent.
And so when you think about healthcare and the cost of care and utilization of resources, is there a care management function that you're offering to these patients, or is that you, the provider, or do you have care managers in your office?
I think a lot of our goal is to manage care for our patients directly.
Right.
You know, it's kind of gotten away from us over the last few years, and so we're trying to get back to taking care of especially our more difficult patients.
So then you're talking about advanced directives and palliative care and all those
Absolutely.
things. It's you
Yep,
to
absolutely.
do that. Okay,
Yes.
perfect. Thank you.
And I just want to add to that, I'm not a doctor up here, obviously, but my wife actually, we didn't go over this, she's actually a pediatrician. And she worked in a 3-physician practice. And if you want to know what really drove me to get interest in this, is because, as Dr. Fisher said, right now our current healthcare system, especially around insurance, is broke. In that 3-physician practice, one of her fellow doctors literally worked himself to death. This guy was working 80-hour weeks, staying up, focused on taking care of the patients. He left every other aspect of his life to go to pot, essentially. And we experienced that firsthand. I was out there changing fluorescent light bulbs in their patient rooms because they didn't have time to do that. I was doing the data recovery for them because they put everything that they had into this. When you talk about 2/3 of the doctor's time under the current insurance model-based practices being put into the paperwork and the bureaucracy that just saps the soul of a doctor who's in their heart really want to take care of their patients, it dries it out. And my wife is no longer practicing medicine. So if you want to know why I'm passionate about this and why I'm driving all the way across the state to go off and tell everybody about the opportunity you have with these great doctors, that's why I'm here. This is something revolutionary, and the people that benefit most from it are not even the doctors, because it's actually you, the patient. So I just want to make sure you're aware that that's what's driving me.
I think it's a wonderful program that you're offering. However, I'm older, and I have a husband who's kind of bionic. He has a knee, 2 hips, a back, and just had triple bypass. Now, I don't think any of you could handle any of that. So I know you could refer, but, how do we get around all that? You have to have all of this. Actually, we do have a Cadillac plan, in that we have Plan F, and luckily we are able to afford it. However, we don't ever have to pay anything. I don't say a bill or anything. Everything's he just walks in, walks out, and it works great for us. But, just adding on this extra, and I don't know how what you do, can affect people like us that are really at other doctors' offices.
Well, you're right. There are limitations in our scope of practice. We're primary care doctors, family physicians, so we can't do heart surgery or orthopedic surgery, but we can advocate for our patients. We can spend time with our patients. We can make sure that there's not drug-to-drug interactions. So we will need the help of our specialists, and that's where catastrophic coverage insurances can be and are necessary to cover those expensive things. But when it comes to your primary care needs, colds, urinary tract infections, sprained ankles, diabetes, blood pressure, that's stuff we can manage at a much lower cost.
How about the medications and tests that he might, if he has to have any more bionic things done, that you can testing or anything that can fit into your practice or not?
Right, so let's say your husband sees a specialist and the specialist orders a certain amount of blood work. You can bring that lab requisition or order to us. We can put it in our name. It's the same test, same lab, same equipment running the lab. It's just at a lower cost through the direct.
But it already pays for it, what I have. So that means maybe we would need to look for something that was a lower in cost for a supplemental.
And Dr. Savage said it's not, maybe not always cheaper. You know, direct primary care is not cheaper for everyone, but it's, we argue that it's better. We can get better access for other things.
It was just, when we're out there.
Right.
You know,
Oh, sure. Yeah, I'd like to address that. I'm a super specialist. I'm a nephrologist, kidney specialist. So how might a direct primary care practice help a patient who comes and sees me? So the answer, I think, I can't speak about your husband in this specific case. But what I've seen is if I work with the primary care doctor closely, I can prevent, we as a team can prevent a lot of these issues that people end up in catastrophic events. So the direct primary care concept actually, and I can't talk about your specific case, but in the general population will lead to a lower need for all these very complicated procedures.
this might be a little late for us.
Yeah, well, but I'm just talking in general, and I have participated in that model, and it's been very successful.
Just quickly, actually, the more complex you are, the more you need a doctor who can help coordinate it. The sad truth is we become a very organ system-based healthcare system. That's your heart, that's your kidney, that's your liver, whatever. We treat them as though they're not part of the same person. The only doctor who's going to worry about the whole of you is these guys. And they can actually help. So you go for the surgery, fine, but the surgeon's done with you at that point. And the interesting thing is it's very common. There's nothing against my orthopedic colleagues, I love them, but if you have a problem and you're seeing Dr. Fisher because you're in kidney failure, the orthopedist tends to see you and dump you on huge doses of Motrin. Well, that will shut down your kidneys. So who picks that up? So that's where the primary care doctor, that's usually, the concept of the whole system is actually moving that way, whether you're doing this model or not, but the only people who actually have the time and the ability to do it is this model. The more complex you are, the more you need a coordinating doctor.
This is really population health, opposed to population medicine, right? I mean, instead of population medicine, you're focusing on the PRD, you're doing the whole.
The population management is interesting. Again, it's a movement over healthcare system to look at groups of people and health of groups of people. Well, the best way to handle a group of people is one person at a time.
Right in front of you, at the bottom. We have brochures that are available too that has our website on it. So I think there were a couple answers. If you guys don't mind stepping to the microphone so everybody can hear, there's one here and there. Thank you.
Are there other practices in the area that are also working on migrating to this model?
I'm not aware of any. So are there any practices in this area migrating to this model? We've not heard from any others, but we know that we're under a microscope right now. So we know that others are watching.
Grand Rapids is probably, there's like 4 practices in Grand Rapids.
Yes.
Hi, thanks very much. Question is, I know there's current federal legislation or being proposed to allow HSA dollars to fund this, your membership fees. I know that my last bit of research said that's not really gone forward yet completely. So any just updates on the probability of that? And that's a really advantageous aspect for someone in my case, for my family. So I'd like to know if you have any insights on the probability of that going forward. Thank you.
All right. The good news is I think you're going to get some action. It's HR 365 is the one that expands it to HSAs. I've also got legislation at the state trying to prompt the federal government to expand access directly for the direct primary care services under CMS, so that's Medicaid and Medicare. So those are kind of the 2 big initiatives. The good news is the Secretary of HHS is an advocate. We worked hard to make sure we had somebody like that in that place to go off and make that decision. So some of what we're talking about, some of the openings that we're looking at, doesn't necessarily even depend upon the passage of HR 365. Some of these are in the 20,000 pages of rules that go along with the Obamacare, and we've got people in those positions. When you listen closely to what Dr. Tom Price talks about when he's on the talk shows, he talks about it in terms of stages. And one of those stages is regulatory reform and changing some of those rules. These regulations have their own timeline where you propose a rule and it takes something like 180 days of review and then it gets actually rescinded. That is another mechanism that's going to happen, and that doesn't require Congress talking to the Senate and all getting together and singing Kumbaya, which doesn't seem to be happening very often sometimes. So there are some things that are being done at the executive level, and Dr. Tom Price has already alluded to that. So, but the big shifts around HSAs and around CMS, we'd like to see that put into statute, which means that we got to get the House and the Senate, with that Kumbaya moment. And I've got good indications that September is going to be another renewed push towards this end, we'll see how that turns out.
If you're in a direct primary care program and you're diagnosed with a condition and then you move to an area that doesn't have direct primary care, is that going to be considered a pre-existing condition?
If you guys mind, first and foremost, direct primary care doesn't care about pre-existing conditions because it's not a risk model anymore, and so you're not worrying about whether or not somebody has a probability of having something or not. They have it. There's a service that you're actually getting. It's something to receive, like the oil changes in your car or whatever. So pre-existing conditions have no basis whatsoever in context of a direct primary care service model. I mean, if you're sick, like Chad was talking about before, bring me it's like the inscription on the Statue of Liberty, bring me you're tired, you're poor, you're ill, because that's what I'm here for. I'm here to take care of you and provide care. If you shift over in pre-existing condition, your catastrophic coverage, if you need to go off and kick into that, that's when that plays in. And it's into that, because that's where the risk model actually plays in, is on that side. So if you've already got insurance and you get a condition, odds are the insurance is already covering that. You're already taken care of in that context. If you didn't have insurance, and then you sit there and, oops, my house is on fire, now I need to get home insurance, that's a different discussion altogether. Does that make sense? Yeah.
All right. Thank you very much, everyone, for coming. If you have any other questions, we're up front. If you want to come on up. Thanks so much.
You don't have a choice. Yes. Yeah.